Just like in skeletal muscles, cardiac muscles also experience a refractory period, and that occurs due to the inability of sodium channels to react to a new stimulus, either because they are already open or because they are closed and temporarily inactive. Whereas in skeletal muscles, refractory period lasts just a few milliseconds, 1 or 2 milliseconds, and contraction may last up to 100 milliseconds. The skeletal muscles are capable of experiencing tetanus. In other words, they can go in a contraction state and stay contracted. Whereas in cardiac muscle, the refractory period is significantly longer. Refractory period lasts through most of the action potential. It lasts through the entire plateau and most of the repolarization period. In other words, it lasts as long as the contraction itself. Why is there such a difference, and what is the need for this difference? In the heart, it is absolutely essential that we experience periods of relaxation. If a heart goes in a contraction and stay contracted, is that working at all? No, because in a relaxation period, it needs to refill with blood so that the next contraction is efficient in providing the blood flow through the cardiovascular system. Also, perhaps you're wondering, who cares? I'm just going to do ultrasound and I'm just going to do radiology. I don't really care about those channels, and how am I ever going to use that? You'd be surprised. Actually, a lot of the drugs that our patients receive for various heart problems address different channels in their cardiac muscle. For example, sodium channel blockers are used to treat tachyarrhythmias. So sodium channels, when they blocked, of course we don't want to block all of them because then the heart would not be excitable. So we will block majority of them with medication like quinidine. That will slow down the influx of sodium. Therefore, the depolarization phase lasts longer, like we have on this red dotted line, and therefore refractory period is longer. So heart is not excitable for a longer period of time. What do we accomplish? We decrease the heart rate. Another example would be a potassium channel blocker, like amiodarone. If we block many potassium channels, again, we don't want to block all of them, so that would be definitely an overdose. Then the repolarization takes a little longer, and so the overall length of the action potential and therefore the refractory period is longer, and heart is not excitable for a longer period of time. Hence, we decrease the heart rate. Again, we use that to treat tachyarrhythmias. Calcium channel blockers. What do you think calcium channel blockers would accomplish? And therefore, the action potential will become shorter. However, calcium also is important for a muscle contraction itself, right? So when we block calcium channels, less calcium enters in, and the cardiac muscle is not contracting as forcefully. So the two drugs in this category are verapamil and nifedipine, are used to not so much treat the tachyarrhythmias, but to decrease the force of a myocardial contraction. One of these drugs is more efficient in affecting the heart, the other one works on the smooth muscles in the vessels, but both of them basically work in a similar way by blocking calcium channels and therefore decreasing the force of muscular contraction. And again, I want you to understand that this is not a pharmacology class. You're not responsible for knowing the names of the drugs and their action. However, it is helpful for you to see why you need to learn about different channels as they act in cardiac muscle.
Calcium channel blockers. Amlodipine inhibits the movement of the mineral calcium into the muscle cells of the heart and arteries. Because calcium is needed for the heart to contract, this decreases the force of the heart's pumping, thereby lowering blood pressure. Amlodipine is used to treat high blood pressure and is also prescribed for patients with angina, which is a painful constriction of the heart due to a lack of adequate blood supply.